outset, let me thank the ISA Vishakhapatnam City branch, especially Dr. Anuradha ma'am and Dr. Praveen sir for giving me the opportunity. So, when I thought we had to present the case of lung for bronchiectasis, I thought it will be going to be a lot of big discussions, sir, in fact. So, we have tried our best to keep it crisp and creamy. So, without further delay, I request Dr. Deepika, or final year postgraduate, to present her case. Yes, Deepika.
Good evening, sir.
Yes, present the case.
Sir, I'm present. Good evening, everyone. I'm Dr. Deepika, postgraduate from Maharaja Institute of Medical Sciences. Now I'm going to present a case presentation on bronchiectasis. Coming to the case, a 47-year-old male patient by name B. Shankar Rao, resident of Nallimadla, farmer by occupation, came with chief complaints of cough with expectoration since 3 years, breathlessness on exertion since 2 years, and occasional hemoptysis since 1 year.
Hello.
History of present illness. The patient complained of cough with expectoration since 3 years, aggravated in the last 1 month, insidious in onset, gradually progressive, more during early morning, associated with postural variation, aggravated in supine and left lateral position, relieved on sitting. Copious amounts of foul smelling, purulent yellow sputum, aggravated since 1 month. Breathlessness since 2 years, insidious in onset, gradually progressive, aggravated with cough and non-exertion, relieved with rest, initially breathlessness while walking uphill, now breathlessness even while walking short distance. Coming to the hemoptysis, 3 episodes in the past 1 year. Last episode was 5 months ago. Around 50 ml of fluid mixed with sputum. Not associated with food particles, no history of hematuria, bleeding tendencies, and intake of anticoagulants. No history of chest pain, palpitations and syncope, loss of weight, appetite, evening rise of temperature, night sweats. Coming to the past history, history of similar complaints from 3 years, history of hospitalization following breathlessness and hemoptysis 5 months ago and was treated with medications. Known hypertensive since 1 year and on tablet amlodipine 5 mg OD. Not a known case of diabetes, TB, CVA, asthma and seizures. No history of any surgeries in the past and no history of any drug allergies. Coming to the family history, there were no similar complaints in the family. Coming to the personal history, patient takes mixed diet, sleep and appetite are normal, bowel and bladder habits are regular, married with 2 kids, known smoker since 30 years, 10 cigars per day, 15 pack years, stopped 1 month ago, not a known alcoholic. Coming to the general physical examination, patient is conscious and coherent, ill-built and nourished, weight of 50 kgs, height 170 centimeters, and BMI of 17.3 kgs per meter square. There is pallor present and clubbing present, no icterus, cyanosis, lymphadenopathy, and edema, no uses of accessory muscles, and his JBP is normal. Coming to his vitals, blood pressure of 140 by 8 mmHg in supine position, obtained in left arm, pulse rate 64 beats per minute, regular rhythm, normal volume, all peripheral pulses are felt, no radiofemoral delay or radial delay, respiratory rate of 20 per minute, regular and abdominothoracic type, and he is febrile, and his room air saturation is 95%. Coming to the airway examination, is having an inter-incision distance of 3 finger breadth, thyromental distance of 3 finger breadth, no dentures and no loose tooth. Neck movements were normal, Mallampati of grade 2, temporomandibular joint movements were normal, and the trachea is in midline. Coming to the systemic examination, respiratory system inspection, upper respiratory tract, nose, nasal septum, and paranasal sciences appear to be normal. No postnasal drip or pharyngeal congestion. Chest appears to be bilaterally symmetrical in shape. Movements of the chest appears to be bilaterally equal. Trachea appears to be in midline. Apical pulse seen in the fifth intercostal space. Skin over chest wall appears to be normal. No visible pulsations, dilated veins, scars or sinuses. no intercostal indrawing or drooping of shoulder, no kyphosis and scoliosis, no subcutaneous lesions, and no prominence of accessory muscle usage. Coming to the palpation, all inspectory findings are confirmed. Trachea is in midline. Apical limbus is felt in the left fifth intercostal space, 1 centimeter medial to mid clavicular line. Movement of the chest wall is equal in both right and left hemithorax. Chest expansion at the level of the nipple during deep inspiration is 5 to 8 centimeters. Tactile vocal fremitus is felt and are equal on both sides of the chest. No palpable pleural fixal drop and no palpable crackles or rales, V's or rhonchi. Coming to the percussion, dull note over left infraaxillary and left infrascapular region, resonant note over all other areas, no shifting dullness. On the auscultation, there were normal vesicular breath sounds were heard over the right lung. Diminished breath sounds with coarse leathery crackles were heard in the left infraaxillary and left infrascapular region. Coming to the cardiovascular examination, regular rate and rhythm with no murmurs, rubs or gallops. Apical impulse felt at fifth intercostal space, 0.5 centimeter medial to mid-clavicular line. On percussion, right border of the heart corresponds to the third and fourth intercostal space on the left parasternal line, and there are no associated heart diseases. Coming to the gastrointestinal, bowel sounds were present, no bruits or pulsatile mass, soft on palpation, and no tenderness on superficial or deep palpation, no hepatosplenomegaly. Coming to the central nervous system examination, higher mental functions are normal, along with all other sensory or motor modalities, no signs of upper motor neuron or the lower motor neuron lesions, and the reflexes were normal. Coming to the summary, a 47-year-old a 47-year-old male with chief complaints of cough since 3 years, associated with sputum, which is copious in amount, foul smelling, and yellowish in color, breathlessness on exertion since 2 years, and occasional hemoptysis since 1 year, who is a known hypertensive and chronic smoker. On examination, has clubbing, and on auscultation, coarse leathery crepitations are present in the left infraaxillary and left infrascapular region, most probably left lower lobe bronchiectasis.
Thank you, Deepika. Good evening, Dr. Shankara sir. Good to see you. So that is the case presentation. So, Dr. Deepika,
So,
yeah. Can you define dyspnea?
So dyspnea is the undue awareness of the respiratory effort of the patient. And the dyspnea is graded according to the MMRC classification. And the MMRC classification includes 5 grades of grade 0 to grade 4. Grade 0, breathlessness only present on the sternus exercises. Grade 1, shortness of breath when walking uphill. Or grade 2, walks lower than contemporaries on the level because of the breathlessness. And grade 3, stops for breath after walking for an 100-meter distance. And grade 4, two breathlessness to leave the house or two breathlessness when dressing or undressing.
What is the grade of this patient, sir?
So initially the grade of this patient was grade 2, sir. Then now at presentation the grade was the grade 3, sir.
So what was the patient, what was the planned surgery? Why did
Left
he?
lower lobectomy, sir. Left lower lobe lobectomy, sir.
Original diagnosis was bronchiectasis, right?
Yes.
What are the differential diagnosis of the case?
So the differential diagnosis includes lung abscess, tuberculosis, necrotizing pneumonitis, and aspergillosis, bronchopulmonary aspergillosis.
How do you check the effort tolerance in this patient?
The effort tolerance is checked by the metabolic equivalence, sir. The metabolic equivalence in this patient is of 4, sir. Like the patient is able to climb a few stairs and he's walking on the level grounds and he's running and he's able to do his heavy household chores. So the metabolic equivalence of this patient is METS 4, sir, greater than 4.
So what is the difference? How do you differentiate acute from chronic cough?
The acute cough, we'll see if the duration is less than 3 weeks, we'll say it is an acute cough. If it is lasting for more than 8 weeks, then we'll say it is a chronic cough.
What is the nature of the sputum in a bronchiectasis case?
In the bronchiectasis, the sputum is of the sputum production is copious amounts of sputum, and it is foul smelling and purulent. And the nature of the sputum production is three-layer nature will be present, sir. It will be an foamy upper layer, and the middle mucoid layer, and the lower purulent layers.
What do you mean by copious amounts?
Copious amounts is if the sputum production is greater than 100 ml per day, then we'll say it's the copious amounts of sputum production.
So what are the common causes of bronchiectasis and what features? What features predispose to bronchiectasis?
So the common causes will be an infective causes and the non-infective causes, sir. Infective causes will be because of the pneumonia, and the pneumonia is because of again bacterial and the viral. In the bacterial, the most commonly because of Mycobacterium tuberculosis, Mycobacterium avium, Staphylococcus aureus, and in the viral, it is mainly because of adenovirus. And in the non-infectious causes, because of aspiration pneumonia or because of any obstruction, and immunological causes like allergic bronchopulmonary aspergillosis, and the predisposable factors like congenital factors like primary ciliary dyskinesia, most commonly Carter-Jenner syndrome, or if the patient is any immunocompromised because of any immunocompromised disease like HIV, and any ciliary dysfunction diseases like cystic fibrosis.
What are the clinical features of bronchiectasis?
The symptoms will be of recurrent cough with purulent sputum production, and there will be recurrent upper tract infections, and there may be chances of hemoptysis. And the chronic, if there is long-standing cases, there may be chances of cor pulmonary and right ventricular failure. And coming to the signs, there will be variable auscultatory findings like crepitations, wheeze, and bronchial breath sounds. On examination, there may be clubbing, and the long-standing cases again will be having signs of cor pulmonary and right ventricular failure.
So you mentioned hemoptysis, right? What is the cause of hemoptysis in this patient? What might be the cause?
Because of the chronic suppuratory inflammation, there will be neovascularization of the bronchial vasculature in the bronchiectasis, sir. And on addition suppurative diseases, these neovascular vessels will rupture, and that will lead to the hemoptysis in the bronchiectasis patient.
So this patient is posted for left lower lobe lobectomy, is that right?
Yes.
Yeah, just Deepika, can you quantify what about hemoptysis? How much quantity wise? Has he got mild hemoptysis or?
So, mom, mild hemoptysis, mom, less than 50 ml per day.
Okay. So it is not massive.
No,
Massive
ma'am,
means
not massive.
more than 500 ml like that. Okay,
Yes.
it is for lower degree, mild degree. Okay,
Okay,
next.
ma'am.
Krishna.
Yeah, okay. So what are the investigations you will suggest for this patient?
So the investigations routinely like complete blood picture, sir. We'll be seeing elevated white blood count in these patients, and if in the elevated white blood counts, if it is neutrophil dominant, it suggests of bacterial etiology, and if it is lymphocytic predominance, it suggests of tuberculosis. And then we'll be advising, as we are posting for a major surgery, we'll be advising liver function test and renal function test, and we'll be advising fibrinogen levels as it correlates with the severity of the bronchiectasis. Chest X-ray. Chest X-ray is done to rule out any, to see the extent of the bronchiectasis and to rule out any pleural effusions, and to rule out any cavitary lesions, and to see the possible position of the trachea, and to see if there is any shifting of trachea is present. And we can do CT thorax also, again to check the extent of the bronchiectasis and to measure the diameter, tracheal diameter, which will be useful for the size of the double lumen tubes further. And we'll be advising ECG also, ECG to see the signs of any pulmonary hypertension present, and the spirometry and the diffusing capacity of lung for carbon monoxide. And these are done to see the severity of the dysfunction and to check for the response of the bronchodilator therapy, and also to assess the suitability for the lung resection. and the room air oxygen saturations to check for the baseline hypoxemia. And we'll advise ABG also, 2D echo to check for any signs of the pulmonary hypertension and right ventricular size, and the sputum and gram stain and culture sensitivity of the organisms to see to give the specific antibiotics for the patient.
Anything else?
In HRCT, we can also do, sir. It is a gold standard thing for the bronchiectasis. In the HRCT, we'll be seeing if it is an horizontal bronchi, we'll be seeing signet ring appearance, and if it is a vertical thing, we'll be seeing tramline appearance. And we can see that the internal diameter of the bronchi will be greater than that of the artery. The bronchi-artery ratio will be greater than 1.5, and there will be no tapering of the bronchi towards the periphery. There will be air wall thickening will be present in the HRCTs.
So how do you want to do you want to do any bedside pulmonary function tests?
Yes, sir. Bedside pulmonary function tests are done. So we'll be doing bedside pulmonary function like a Strider match test, sir. In this Strider match test, you'll make the patient chin supported or rested, and you light the match at a distance of 6 inches, and you'll ask the patient to take a deep blow and exhale forcibly with the mouth wide open. And if he is able to blow that, we can say that maximum breathing capacity is greater than 60 liters per minute. And if he is able to do that at a distance from 9 inches, we can say that his maximum breathing capacity is greater than 150 liters per minute. And if he is able to blow at 3 inches, and maximum breathing capacity will be greater than 40 liters per minute. And the next is Sebris breath holding test, and it assesses the overall cardiopulmonary reserve of the patient. In this, you'll ask the patient to take a full breath, and you'll ask the patient to hold it as long as possible. If it is greater than 25 seconds, then it is normal. If it is less than 15 seconds, then it is a poor cardiopulmonary reserve. And then the next is Sebris single breath count, and this tests the vital capacity. You'll ask the patient to take the deep breath and then exhale counting from 1 to 3. And if it is normal, if the patient is able to count for greater than 40, and it indicates the normal vital capacity. And there is another test called cough test, and it also measures the vital capacity and the respiratory muscle strength. And in this, you'll ask the patient to take a deep breath and then cough forcibly. And if the patient is able to cough effectively, then he is having a good vital capacity and good respiratory muscle strength. And if there is a weak or ineffective cough, it is again an indicator for forced vital capacity less than 20 ml per kg. And if there is any recurrent or paroxysmals of the cough present, then there will be increased risk of post-operative pulmonary complications in the patient.
Can you describe the three-leg stool criteria in this patient?
So in the three-leg stool criteria, we will be seeing the lung mechanics and the lung parenchyma and the cardiopulmonary reserve. In the lung mechanics, you will be seeing for the predicted post-operative FVV1 and predicted post-operative DLCO. And this gives the overall assessment of the patient, and it is a vital parameter to see the risk assessment algorithm. And for the lung parenchyma monitoring, initially we used to do an ABG, and if the ABG, the PaCO2 levels is greater than 45 mmHg, and the saturation is less than 90%, and PO2 less than 60 mmHg, we'll be taking them as risk factors. But now we are more dependent on DLCO, as it is an independent predictor for poor outcome after lung resection, and it is also the most useful test for gaseous exchange. And if the predicted post-operative DLCO is less than 40%, again we can assess that there will be increased respiratory and cardiopulmonary complications in the patient. And then the next is the cardiopulmonary reserve. In the cardiopulmonary reserve, we'll be testing the patient with stair climbing, shuttle walk test, and the 6-minute walk test. And in the stair climbing test, you'll ask the patient to take a flight of stairs. And if the patient is unable to take if the patient is taking a less than 2 flights, then the patient is considered as high risk. And if the patient is unable to complete 25 shuttles, then the maximum oxygen consumption of the patient is less than 15 ml per kg per minute. Again, he is also considered as a high risk patient for the surgery. and 6 minutes walk test if the patient is having less than is able to walk less than 2000 feet. Then again the maximum oxygen consumption is less than 15 ml per kg per minute, and if there is desaturation greater than 4%, again there is increased risk of post-operative complications. And this is all the three-legged stool criteria, and this is the primary criteria. And if this primary criteria is not met, we'll be going for the second phase criteria. In this, we'll be causing the temporary occlusion of the corresponding mainstem bronchi or the pulmonary artery, and we will see if there is any increase in the pulmonary artery pressure. If the pulmonary artery pressure is greater than 45 mmHg, or PaCO2 is greater than 60 mmHg, or if there is any fall in the PaO2 less than 45%, then the patient is considered and he is inability to tolerate the lung resection. So we will be not going with the lung resection in this patient.
Deepika, can you say me what is a flight of stair? How to define it?
Sir, flight of stairs is will be considering as 20 steps, sir. At 20 steps of 6 inches height is considered as one flight. One flight.
Will you do the PPO after bronchodilator or before bronchodilator? Is there a relation bronchodilator?
Yes, after bronchodilator, we'll be doing that. We'll be considering the reversal, sir. If it is greater than 12%, we'll consider if there is reversibility with the bronchodilators.
Okay.
Okay, Deepak, can you break down and evaluate lung resection with that formula?
Then predicted post-operative FEV1 is equal to, we'll be calculating with preoperative FEV1 into 1 minus number of the subsegments removed divided by 42, sir. And if it is less than 40% of the normal predicted value, we will consider it as high risk for post-operative pulmonary complications.
What do you mean 42 subsegments? Is it for a single or both lungs?
So in the left lobe, in the left lung, the upper lobe is divided into 10 subsegments, and the lower lobe is divided into 10 subsegments. And in the right lung, the upper lobe is divided into 6 subsegments, and the middle lobe is divided into 4 subsegments, and the lower lobe is divided into 12 subsegments. So totally an entirely of 42 subsegments.
Any other formula?
So, and the formula is preoperative FEV1 into 1 minus percentage of the functional lung tissue removed by 100%. And another thing is by calculating the Y by G, that we'll be calculating by the number of functional segments removed by the total segments present.
Total functional segments present.
Total functions.
So what is the algorithm for lobectomy? What is the algorithm you would follow for this patient?
Sir?
What is the algorithm you would follow for this
values
patient?
you have got?
The algorithm is we'll be
Choose only
taking
one.
the predicted post-operative FEV1 and the predicted post-operative DLCO. If both the values is greater than 60%, then the patient is considered for low risk, sir. And if either of the values is less than 60%, and if one of the values is if either the values is the less than 60% and both the values are greater than 30%, then we will be subjecting the patient to the stair climbing test and shuttle walk test, sir. If the stair climbing test is greater than 22 meters, or shuttle walk test is greater than 400 meters, then we will again grade the patient as low risk. But if the stair climbing test is less than 22 meters and shuttle walk test is less than 400 meters, then we will be subjecting the patient to cardiopulmonary excess testing. And in the cardiopulmonary excess testing, if the maximum oxygen consumption is greater than 20 ml per kg per minute, then we will be taking the patient as low risk. And if it is between 10 to 20 ml per kg per minute, we will be taking the patient as moderate risk. And if he is less than 10 ml per kg per minute, we will be taking the patient as high risk. And if the post-operative FEV1 and DLCO both are less than 30%, directly we will be subjecting the patient to the cardiopulmonary exercise testing. And again, if it is less than 10 ml per kg per minute, we will be grading the patient as high risk. This is the algorithm for thoracotomy and major anatomical resection.
Which is the algorithm and what is the name of this algorithm? Who suggested this? This is recommended by
American.
yes, American College of Chest Physicians. Okay, right. So you have followed the algorithm. Now you want to optimize the patient. How would you optimize this patient and prepare him for the lobectomy proposed?
So there are five elements of the preoperative regimen, sir. You'll ask first you'll ask the patient to stop the smoking. Ideally, greater than 8 weeks, they should be stopping of the smoking, and you'll be dilating the airways with the bronchodilators, and you'll be giving inhaled corticosteroids to decrease the exacerbations of the illness. And you'll be treating the patients. You'll treat the patients with mucolytics and hydration to loosen the secretions present. And you'll facilitate the post-operative care, and you'll check for
Anything
the
about the secretions? Anything about physiotherapy? Anything about
chest
postal
physiotherapy.
drainages?
Preoperative chest physiotherapy is advised, sir, and the postal drainage is also recommended for the patient. Incentive spirometry is also recommended for the patient.
Yeah, Deepika, can you just say detailedly something about smoking, how it is going to affect at the different
Ma'am,
phases?
smoking, if the patient stops smoking, like
No,
1 to
ma'am is asking what are the effects of smoking. Then go to
uh,
the
smoking on the CVS, there
First
will
12
be
hours.
adrenergic,
Hmm.
there will be adrenergic stimulation, and the sympathetic stimulation will be present, ma'am. So there will be increase in the blood pressure, and there will be increase in the peripheral vascular resistance of the patient. There will be increase in the heart rate of the patient. And coming to the
The first 12
coagulant.
hours, in the first 12 to 24 hours, basically, what is going to
First
happen?
12 to 24 hours, there will be reduced carbon monoxide and the nicotine levels. And for
Yes.
the next 48 to 72 hours, carboxyhemoglobin levels will become normal. And the ciliary movements will also, no, ciliary movements also will be normal. And 1 to 2 weeks, the sputum production will be reduced. And
Yes.
3 to 4 weeks, wound healing will be normal in the patients. And 4 to 6 weeks, pulmonary function test will be improved, and
Yes.
6 to 8 weeks, immune function and metabolism of the patient will become normal, and 8 to 12 weeks, there will be reduced post-operative mortality and morbidity in the patients, and there will be 4 times reduced post-operative pulmonary complications. And if it is greater than 6 months, the risk will be equal to that as the non-smoker.
Yes, good, good.
so now you have optimized the patient. So when can you take the patient for surgery? What are the
So if
points you
the
consider?
sputum production is less than 40 ml per day, and the sputum is of non-purulent, and if it is non-foul smelling, and if the disease is localized, then we can take the patient for surgeries.
Okay, so you want to go for anesthetizing the patient for a left lower lobectomy, right? Is that right? So how do you want to prepare the OT? What is your plan?
So the technique of anesthesia will be general anesthesia with thoracic epidural analgesia, sir, with the controlled ventilation, and we'll be keeping all the in the OT. We'll be keeping monitors like ECG and pulse oximetry, capnography, and in non-invasive blood pressure and temperature monitoring, and invasive monitoring like arterial monitoring and central venous pressure monitoring is also kept ready. And anesthesia is administered in a secretion retaining position of the left lower abscess. That is, we'll be keeping the left side. The patient will be dependent while inducing the patient. Rapid sequence induction is done to avoid prolonged positive pressure ventilation, which can again increases the chance of spillage. And we'll be giving adequate pre-oxygenation to prevent the hypoxia. And you will be intubating the patient with double lumen tubes, and followed by we'll be isolating the lung. And this lung isolation can be achieved while the patient is awake, especially in situations where amount of secretions continues to be high in spite of all the efforts. We'll be intubating with the patient with the double lumen tubes.
Yeah. Do you want to consider anything else before giving general anesthesia to this patient?
Like, we'll be giving thoracic epidural
Yeah,
first,
when
giving
usually
thoracic
cases
epidural first,
before.
and then we'll be intubating the patient.
Yes.
Do you want to keep any fiber optic bronchoscope for this
Yes,
patient?
sir. Pediatric fiber optic bronchoscopy is
What is the
preferred.
size? What is the size? What is size of bronchoscope?
It's 3 to 4.2 millimeters. Okay, fiber optic bronchoscope of pediatric size, right? So you want to go for one lung ventilation.
Yes.
What is the purpose of one lung ventilation? Why do you want to do that?
So to avoid the spillage of the one separation of first to separate the one lung from the other, sir, to avoid the spillage of the secretions and to control the distribution of the ventilation and to provide surgical exposure for the patient for the surgeon. So we'll be going with one lung ventilation, so we can collapse the one lung.
How do you achieve one lung ventilation? What are the methods used for?
So the one lung ventilation can be achieved with double lumen tubes or single lumen tubes with bronchial blockers and endobronchial tubes.
So how do you select the size of the double lumen tubes if you want to go with the double lumen tube?
So double lumen tubes, ideally in the male patients, we'll be taking 39 and 41 French, sir, and in the females, 35 and 37 French. Again, the selection is done on the patient's height, sir. In the females, if the patient is of less than 160 centimeters, we'll be going with the 35 French. If the patient is greater than 160 centimeters, 37 French. In the males, if the patient is less than 170 centimeters height, we'll be taking 39 French. If the patient is greater than 170 centimeters height, 41 French. And this
Very
selection
short
is also
females?
done by the tracheal diameter also. So if the
What about in very short females? Excuse me. What about a very short female, less than 150 centimeters height? Which size would
uh,
you go?
It is the
like
smallest rather which is available.
35 French.
No.
32.
You
26
should have checked.
shortest, right?
Okay. 28 is available. 32 is available.
26, 28, 32.
26 is
Yeah.
the shortest.
So you can go for a 32 tube, right? So which sided tube do you want to select? What is most commonly, which is the most common sided tube used in double lumen tubes?
Left-sided tubes are the most commonly used double lumen tubes, sir, because the marginal safety is more in the left-sided tubes because the opening from the from the carina to the right upper lobe is 1.5 to 2 centimeters, whereas on the left side it is nearly 5 centimeters. So the marginal safety is more on the left side. So most commonly left-sided tubes are preferred.
I mean, what do you mean? If you insert a right sided tube, what will happen?
If you insert the right sided tube, there may be chance of upper lobe obstruction to the patient, and there will be hypoxia.
It need not be accidental. Even with an elective intubation, right sided tube, there is high risk of high chances of the blockade of the right upper lobe bronchus. Okay.
In what
So you go
conditions
with-
you go for the right-sided tube?
If there is any exophytic tumors which is blocking the entrance of the left bronchus, or if there is any intraluminal tumors which is blocking the entrance of the left bronchus, or if there is we are operating on the left-sided left-sided surgeries and left bronchus shunt is present, or if there is any left-sided tracheobronchial destruction, then we'll be going for right-sided tubes.
Aneurysm also. Any aneurysm obstructing.
Yes, sir. Descending
Thoracic aneurysm.
aortic
Any
aneurysm also can
obstructing,
be
aneurysm obstructing the left bronchus.
observed.
So how do you intubate this patient? Can you describe the steps of insertion of double lumen tube?
So the double lumen tube is passed with the distal curvature. Initially,
First of all, how do you determine the size by looking at the tube?
sir,
Which side it is? Can you determine by looking at the tube? How do you know which side
the
it is?
concavity will be present on the left side if it is a double lumen tube, and right side if it is a right side.
How many curves are there?
Two
How many curves? Right.
two concavities will be present.
Hmm.
Yes, please continue.
So the double lumen tube is passed with the distal curve initially concave anteriorly. Then after the tube it passes the larynx, then we'll be removing the stylet, and we'll be turning the tube 90 degrees to the right side, so that the endobronchial intubation is done in the right side. So after rotation, the tube is advanced till we hear a resistance. Ideally, we'll go to a depth of insertion of 29 centimeters. And again, it varies on the height of the patient, sir. If there is an increase or decrease in the 10 centimeters height of the patient, the depth of insertion will be varies by 1 centimeters above and below. So then after the incision, you will be inflating the tracheal cuff, sir, and you will be hearing both lungs should be auscultated for equal ventilation. And if breath sounds are not equal, then probably you may have advanced further more into the main stem bronchus. Then the tube should be withdrawn until the breath sounds are equal bilaterally. Then the second step will be, you will be clamping the tracheal lumen, and you will be opening the tracheal cap, and slowly you will be inflating the bronchial cuff, sir, so that the bronchial cuff is so slowly inflated, and there will be no air leak from the bronchial lumen around the bronchial cuff. And this ensures that the bronchial cuff is not excessively insufflated. And then the third step will be to remove the clamp, and you have to check for after inflating the bronchial cuff, you have to check for both the lungs are ventilated or not, so that we can confirm that bronchial cuff is not obstructing any other contralateral bronchus, either totally or the partially. So the final step will be that you will be clamping each side selectively, and you will have to watch for the absence of the movements of the breath sounds on the ipsilateral side. So the ventilated side should be having a clear breath sounds, and the movement of the shed should be complete, and the peak airway should not be excessively high. And after that, you will be, before only can be conforming with the fiber optic bronchoscope, flexible bronchoscope.
How much air you use to inflate cuff and bronchial cuff and tracheal cuff?
Tracheal cuff 5 to 10 ml of air, sir, and the bronchial cuff 2 to 3 ml of air is sufficient.
So how are you going to confirm the position?
Ma'am?
What are the ways you're going to confirm the position of your
fiber optic bronchoscope, and also by the auscultation, the steps which we discussed.
So you mentioned a fiber optic bronchoscope, right? If you were to pass a fiber optic bronchoscope through the double lumen tube in this patient, right? So you inserted a right-sided tube in this patient. Is that right, or left-sided tube?
Right-sided.
You inserted a right-sided tube. So if you were to pass through the tracheal lumen and you approach the carina, right? What would you see if it was a properly inserted tube?
You will be seeing the right-sided bronchus, like
open, closed. What is it? Do you see a black thing? What is it? What do you see?
You'll be seeing a open thing, the black.
You see any carina, any lumen, or any cuff, bluishness?
You see just
any
the
herniation?
Bronchial cuff.
Yes.
Bronchial cuff will be seen.
Bronchial, where should be? Where it should be?
Should it be
Should be
outside?
just below the carina.
Below the carina.
Just below the carina, not onto the carina.
Yes.
If it is on the carina, it is superficial. Okay. So you have placed the tube. Okay. And now you're trying to ventilate, right? But sounds are not being heard on both sides. What might have happened?
So that we are very superficially present, sir, and that the bronchial cuff is obstructing the tracheal cuff, so that bilateral area.
Tracheal lumen is being obstructed by bronchial cuff.
Bronchial cuff.
Okay, so now you have placed the patient in left lateral or right lateral position?
Sir?
What is the position of the surgery now?
Lateral decubitus position. You'll be keeping in the...
Which lateral I'm asking? Left lateral or right lateral?
Left lateral decubitus position.
You want to operate the patient on the left lung or right lung?
Left lung, right lateral decubitus position.
Don't get confused.
So how are you going to place him? Yeah, can you please describe about the position? How you are supposed to place the patient?
So you will be keeping the dependent. The most lung resections are performed with the lateral decubitus position, ma'am. The with the proper position, it avoids the injuries and it will facilitate the surgical exposure. And in this, the lower arm will be flexed, ma'am, and the upper arm is extended front of the head, pulling the scapula away from the operative field. And the pillows are placed between the arms and between the legs and the axilla, and it is usually positioned just beneath the dependent axilla to reduce the pressure on the inferior shoulder. And the care should be taken to avoid pressures on the eyes and the dependent ear.
Yeah, everywhere. Eyes, retina, like even pinnas, and even lower side, you have all the sciatic, everything you have to take care. Okay, proper padding has to be done where all the nerves have been present.
What precaution you take to roll or shoulder or a dependent shoulder? Dependent chest wall, you want to put a roll, near the axilla. Would you like to take any precaution that?
It is not abducted, sir, so that
What will happen if because of the roll independent below the dependent chest wall?
sir,
If you
to
migrate,
protect
you should not
axillary roll
migrate.
is present to protect on the
You
brachial
should not
plexus.
migrate into the axilla. You should not migrate into the axilla. It should be away from the axilla. Yes. It will compress an neurovascular bundle in the axilla.
Axillary.
Right.
So, what is the ventilation strategy? How do you want to go for protective lung ventilation in these patients for own lung ventilation?
So, lung suppression is done, sir. And in this, while initiating the one lung ventilation, we have to see that the non-dependent lung should be collapsed properly. So when you are initiating the ventilation, you have to give 100% oxygen to the 100% oxygen which should be given, sir. Because if we give air or if nitrogen is present, because of its lower blood gas solubility, it will take more time for the lung to collapse, sir. So initially we'll be giving with 100% oxygen for the non-dependent lung so that the lung collapse. Then after that we'll be inflating the bronchial cuff so for the lung collapse occurs. And in the dependent lung, to prevent the electrophysiologist, we'll be giving with 100% oxygenation and the recruitment manuals. And then we'll be going for lung protection, protection strategies with lower tidal volumes of 5 to 6 ml per kg, and we'll be keeping lower FiO2s of 60 to 80%, and we'll be going with peak airway pressures less than 35 centimeters of water and peak plateau pressures less than 25 centimeters of water, and the respiratory rate is maintained to maintain the normal PaCO2.
What is hypoxic pulmonary vasoconstriction? What is the role of hypoxic pulmonary vasoconstriction in one lung ventilation?
So hypoxic pulmonary vasoconstriction is an autoregulatory phenomenon, sir. In this, what happens is there will be a pulmonary vasoconstriction so that the blood flow is diverted from the hypoxic areas to the non-hypoxic areas, so that the shunt will be decreased by 10 to 20% in this patient, sir. And all the inhalational anesthetics will inhibit the hypoxic pulmonary vasoconstriction, and like vasodilators like nitroglycerin and sodium nitroprusside will inhibit the hypoxic pulmonary vasoconstriction, and any vasoconstrictor like adrenaline and phenylephrine, they will also inhibit the hypoxic pulmonary vasoconstriction. And if there is any changes in the mixed oxygen saturation, like whether low or high, it will cause us it will say that HPV is not effective. And if there are any low or high pulmonary vascular pressures also, HPV will be inhibited.
So you don't want to use inhalation agents when going for on lung ventilation, is that right? You want to avoid inhalation agents?
Yeah, less than 1 mat we can keep. Sir.
Yes. Okay. So how do you manage? Suppose the patient is desaturating when undergoing one lung ventilation, surgery is going on. How do you manage the patient?
If the patient is desaturating suddenly, then we'll be shifting from the one lung ventilation to the two lung ventilation after informing the surgeon. And if there is any gradual decrease in the saturation, you will be increasing the FiO2 to 100%, and you will confirm the position of the double lumen tube with fiber optic bronchoscope, and then you will see the hemodynamics of the patient. And then you'll be giving recruitment manuals on the dependent ventilator lung to eliminate the atelectasis and to improve the shunting. And you will ensure that there is sufficient PEEP to the dependent and non-operative side of the lung. And you can also provide CPAP to the ventilated lung and you can also provide intermittently low flow oxygen to that of the operating lung. And at the end, you will be shifting the patient to the two-lung ventilation after informing the surgeon. And in severe cases, you will ask the surgeon to clamp the pulmonary artery, so to avoid the shunt completely.
So what is lower lung syndrome?
Sir, in the lateral decubitus position, if there is any excessive fluid administration to the patient, because of the gravity, there will be transduction of the fluid to the lower lobes of the lung, so which will causes an hypoxia. There will be shunting, sir, and because of that, there will be prolonged hypoxia, which will be calling as lower lung syndrome.
So on a side note, this patient is undergoing surgery on the left side. Which side do you want to place the central venous catheter? Left side or right side?
So we'll be placing on the right side, sir, so that we will be avoiding the complications like pneumothorax on the ventilating lung. So we will be placing the central venous catheter on the opposite of the operating side.
Are you sure about that? Central venous catheter should be placed on the side which is being operated, right? Because if you puncture the pleura on the non-operated side and the patient lands pneumothorax on the non-operated side, that will
The
be catastrophic.
pneumothorax
Okay. So ideal to place the central venous catheter on the
on
side
the
which is
side of
being
the operating.
operated, right?
So how are
So
you going to do the central venous cannulation?
Ma'am?
So how you would like to do the central venous cannulation? To go
Well,
blindly, or you would like to use?
ultrasound is available, definitely.
So what is other use of ultrasound here when you're placing the DLT? It is coming newly. Earlier we were just sticking on to the FOB. Now once you have done the double lumen tube, you have placed. Do you think ultrasound is going to help you
We can
in
check
differentiating?
the
So the
position.
lung which is being ventilated, you can usually appreciate the pleural lung sliding time, everything will be there. Whereas the lung which has been collapsed, you have the pulsatile nature of it. It is it is the pulsations cardiac which are being reflected. So lung pulsations. So you also have the use of UST.
So,
Now, carry on.
so can the patient be extubated on the table if the surgery was?
Yes, if the patient is awake, warm on all the respiratory and hemodynamics parameters were normal, we can extubate the patient on tables.
What is the plan for post-operative analgesia? How do you want to manage pain?
Pain can be managed by thoracic epidural analgesia, or we can go for any parenteral opioids or any paravertebral blocks or any intercostal blocks, and we can give intrathecal opioids also.
Which is the best among this?
Thoracic epidural analgesia is considered as best.
Okay, so thoracic epidural, and you're planning to give local anesthetic along with opioids. And you have to make sure that the intravenous opioids, if you're going to supplement them, okay, do not complement your thoracic epidural opioids and lead to a complete collapse. Okay, so you have to make sure if you are to go only with IV analgesics with the opioids, you can go for a patient-controlled analgesia. Okay, right. So, what are the post-operative complications you might anticipate in this patient undergoing lobectomy?
So in the pulmonary, we will be having pulmonary edema or any pulmonary torsion can be present, or and in the cardiovascular, arrhythmias can be present, sir, and cardiovascular collapse can be present because of any cardiac herniation.
So
And
what's the cause for arrhythmias that you get?
ma'am,
What might be
atrial
the cause?
fibrillation is the most common thing we'll get.
Yes.
And bronchopleural fistula can be present, and emphysema or any disruption of the bronchial stump, which can lead to the tension pneumothorax. And the neurological complications like recurrent nerve injury or any vagus nerve injury or the phrenic nerve injury can also be present post-operative.
So in post-operative, if you want to continue ventilating the patient, what would be the ventilation strategy in post-operative?
So positive pressure ventilation is ideally avoided, sir, because it will again apply pressure on the stitches. So we'll be avoiding the positive pressure ventilation, sir. So in the post-operatively, we'll supplement oxygenation according to the saturations of the patient.
Yes,
What about
like
the
you
drains
said,
that you're going to keep?
Ma'am?
What about the drains? How many drains they are going to keep for the case of lobectomy?
Like chest drain will be keeping, ma'am. Again, it is a controversial thing because of the chest drain. Also, there may be shifting of the mediastinum and all. So the
Unless you keep a vacuum to that, there will not be
they
mediastinum.
will be keeping a clamp, ma'am.
But usually you allow all the air, accumulated blood, everything to come out, vent it out. Okay.
Yes.
And preferably you would like to have 2 if it is a lobectomy. Pneumonectomy, single is sufficient.
Single.
what would be a catastrophic complication in case the patient had a pneumonectomy? What would be the most catastrophic complication? Sir was saying
Hemorrhage.
this yesterday. Yes,
Hemorrhage,
hemorrhage.
like a mediational shift can be present.
Yes,
Mediational.
mediastinal shift onto the operated side. It can be right side or left side, depending on the side patient underwent surgery. Okay, that can be catastrophic. So, what is the like? If you have extubated the patient, it's all good. What do you want to like? What is the post-operative advice for the patient in the post-op unit?
So you'll be keeping the patient in a semi-upright position, so greater than 30 degrees, and you'll be providing sufficient supplementation of oxygen should be present to maintain a satisfactory saturation, and you'll be giving the patient with in-center spirometry, and you'll be monitoring hemodynamic monitoring should be present, and a post-operative chest X-ray will be doing, and to confirm all the lines will be present, and to see the expansion of both the lung fields, and you have to give adequate analgesia for the patients.
Okay. Sir, I
Just
think
to tell what are the different types of WMN tubes. This
Ma'am?
is just for theory sakes. What are the different types of DL tubes, you know?
Carlin WMN tube, which is an ideally left-sided WMN tube, and Robertshaw WMN tube will be having both right and left in the Robertshaw WMN tube, and you'll be having Silbronco WMN tube and Viva side WMN tube.
Then apart from WMN tubes, what else can you pass?
Bronchial blockers can be used, ma'am. Arnett's bronchial blocker, Fuji bronchial blocker, and Fogarty bronchial blockers. The EZ bronchial blockers.
And Univent also you have.
Univent bronchial.
At least you must know the names, though you use it or not. Okay.
Suppose you want to ventilate post-operative, can you ventilate this patient with a double lumen tube?
No, sir. We have to change to the single lumen tube before shifting the patient to the post-operative wards.
so always have a tube exchanger handy.
Yes.
Ma'am, Shahida ma'am, anything else?
Yeah, nicely you have covered. Very nicely, Krishna Chaitanya Garu.
Thank you. Sir,
Thank you,
Sharma sir.
Chaitanya. Thank you, Chaitanya.
Shankar.
You do very job.
Thank you, sir. Shankar sir.
Thank Deepika did a good, excellent job. Presented very well. Answered all the questions well.
Thank you.
Good
Yes,
job.
very
I have
well.
some questions.
Very well answered, Deepika.
Thank you.
I am Dr. Kuchel Babu. I have
Hello.
some few
Sir,
questions.
good evening,
Good
sir.
evening, sir. Good evening,
Good evening,
sir.
sir.
Good evening, sir.
Yeah, she done well, very well. What is the fluid management, Amma? What is the main important in the fluid therapy?
Sir,
Frequent
restrictive fluid
post-operative.
management is usually given, sir, for 2 ml per kg per hour is ideally given, sir. For totally 24 hour period, will be giving for 20 ml per kg, sir.
For
Max.
24 hours maximum.
Yes, sir. Yes, sir.
Max.
20 ml per kg.
Why it is a fluid management is most important in pneumonectomy?
So we can avoid the complications like lower lung syndromes.
Mhm. Okay. And he asked one question about the complications, immediate to the complications of the after pneumonectomy.
Yes.
You told me something like that, a catastrophic complication. What you told?
Mediastinal shift.
Is it
Cardiac.
called a mediation shift or something? Another name is there. Is it called shift or something like that?
It's called
Mm,
herniation.
herniation.
Not the
Cardiac
shift.
herniation.
It is a mediastinal herniation is the most
Herniation.
dangerous. Huh?
Yes.
One more thing, post-operative management, pain management. You told everything. What is the recent advances of a post epidural? Epidural always has some few complications, kada?
Yes.
Epidural. What are the complications of epidural for thoracic epidural, especially post-operative? What is the complication of epidural?
The,
What should monitor post-operative when you put epidural?
the thoracic epidural.
Any epidural, what is the complication?
A common complication with any
Hypertension.
local anesthetic that you're giving through the epidural.
Hypertension.
Yema?
Hypotension.
Yeah. What is the cause of hypertension in epidural?
Low. Splanchnic vasodilation. There will be systemic vascular resistance.
No, it won't be. You are giving a graded, but only maybe it's few ml, 3 ml, 2 ml. It is a complication. Is the migration of your epidural catheter into the subarachnoid space is very, very
Vertical.
dangerous. That is the most important. Huh? We don't know sometimes. Or bolus sometimes. That is a epidural is a definitely is a not a safe procedure nowadays. What is the latest post-operative pain management? What is the latest guideline says? Is it a post-operative epidural or something in any other another
Something
blocks?
Paravertebral blocks and intercostal nerve blocks.
still more,
No.
still more, which is
Paravertebral
easy,
or intercostal
obvious.
is gone. What more latest?
Your transverse process,
Emma, what is the most important?
something to do with the
What is
transverse
some facial
process.
plane block? What is the facial plane block? What is the
Yeah,
facial plane block? Huh?
you're going to block onto your
Erector
transverse.
spinal block.
Emma?
Erector spinal.
Very good. Huh? That is
Yeah, that's what
erector
I'm
spinal
telling
block.
you, transverse process.
Huh?
Okay.
He's given a clue for you, transfer process. Huh? And that is most important. Nowadays, we just in a preoperatively you can start a rectal spinal block.
Spinal block.
Epidural. Epidural is always a now what are the facial plan blocks are very, very less complications, very good. And there is always you can only unilaterally the pain is only unilateral. Your drug is dissipating the both the
Yes.
both the side, both the system, both the autonomic nervous systems will block. That will cause a complication. That is always better to have a erector spinal
Erector
block.
spinal block.
Now everybody is having ultrasound, or you can give a landmark technical erector spine.
Yes.
Where you give it? How to give it? Can you tell me the procedure of erector spinal block? What is your third year? Your third year only?
Yes.
Yes, sir.
Exam going?
Yes, sir.
Examiners.
What can you tell me the landmark technique or ultrasound guided? What is the procedure? Give erector spinal block. How to give it? Any idea? What is the?
Sir, you'll be making the patient sitting or in the lateral position, sir, and you will be in the needle insertion in the implant technique. The needle it is advanced until
You're
the
talking about the ultrasound guided, not the landmark. Ultrasound guided.
ultrasound guided, sir.
Okay, good.
So the needle is advanced until the tip will be contacting the transverse processor,
How
and
to
then
identify that? How to,
How you're
madam?
going to
What
come?
is your name? What is your name?
Deepika.
No? Deepika,
Sir,
how to identify the transfer process by an ultrasound?
like we'll be identifying 3 centimeters
You can
lateral to the
start.
spinous process.
You can
Difference
start.
between a rib
Most of
and
the
a
times,
transverse process.
easiest
Huh?
method is you're going to start from the ribs.
Ribs.
Where you can appreciate even the pleura which is present beneath. Then as you're going to come medially, then at one point of time, the rounded configuration of the ribs is going to become almost flat-topped, square-shaped. There is a transverse process. And this is the very much easiest block in the truncal blocks, where you have an endpoint like the transverse process and just you're going to hit it and deposit the drug. And there will be craniocaudal spread of the drug. Okay. If it
How much
is
volume? Volume, how much volume?
20 to 30 ml will be giving.
Emma?
not
20
30
to
minutes,
No,
20.
20 to 30 ml of local
How
anesthesia.
many nerves will block if we give a 20 ml? If we given at the L6 level, transverse process L6, we given a 20 ml. How would spread it? Which nerves will block? Which thoracic nerves will block?
So one
20
segment will be taking of 1.5 ml. So 5 segments upon 5 segments.
For every segment, 2 ml is needed.
1.5 to 2 ml is needed for every segment.
Yeah. We
So,
always spread equally. If you should have 5 ml at the
so
T5, 5
5 segments about 5 segments.
up to T2 and B2 is up to 38, 39. Above 4 and below 4, almost. Right. Okay. Most important, he told about the most important post-operative ventilation is very, very dangerous. He asked about the question also. You told me that is you want to avoid it. Sometimes you cannot avoid it. If you not avoid it, what is the what is the strategy post-operative ventilation? Immediate
Gradual weaning criteria we will follow, sir. Gradual
ventilation strategy. And what are the parameters you will most important?
Which mode you want to choose? What is the pressures you want?
Pressure control mode will be choosing, sir. We'll choosing with lower airway pressures will be less than 30 centimeters of water will be choosing. Pressure control.
Okay. Okay. Thank you. Good. All the best.
Thank you, sir. Thank you so much.
Thank you, sir. Thank you, sir.
Shankara, sir.
Oh, yeah. Nicely presented. Congratulations, Chaitanya.
Thank you so much.
It seems to be rapid fire round.
We need to wrap it up, sir, by 7:30. That's why it had to be rapid.
A great initiative by PODS Vizag. I appreciate their efforts, and your training is also very nice. But people should focus on basics first.
Yes, sir.
Basic from, I think, optimization is not covered well. Preoperative optimization should have been better at these postural drainage, everything, those aspects, and all other things are good anyway. Congratulations.
Thank you, sir.
Okay, Chaitanya.
Well done, Deepika. Okay, very well done and very nicely moderated by Krishna Chaitanya.
Thank you, ma'am. Thank you, Shahida, ma'am. Thank you so much.
Yeah.
Dr. Chaitanya.
And even Praveen for giving me this opportunity to be with you and share with you.
It's a pleasure, ma'am. It's a pleasure.
Dr. Praveen, thank you so much.
Thank you, Deepika. Thank you, Chaitanya, for nice session.
Thank you, Anuradha, ma'am. Thank you so much.
Thank you, Annapurna Sharma, sir. Thank you,
madam.
Shankar
Thank you very much,
sir.
madam.
And thank you, Shahida, madam, sir. Madam.
Thank you,
Thank you so much. Thank you.
Thank you.
Wonderful case discussion. So wonderful case discussion by Maharaja Institute of Medical Sciences, anchored by Dr. Krishna Chaitanya perfectly, and great discussion led by the examiners, Dr. B. Annapurna Sharma Garu, Shahida Parveen Madam, Shankar Rao sir, Kuchel Babu sir gave very practical insights. So thank you, sir, for the practical insights you have given. Next, we'll be moving on to the next session, the session of the guest speaker, Perioperative Cardiac Emergencies, Bridging Cardiology Expertise with anesthesiology practice. The guest speaker is Dr. M.S. Chandramouli, DM Cardiology. He is also an electrophysiologist and a device specialist. The moderators for this session are Dr. Vijay Sir, Head of the Department, Anesthesiology, Omni Hospitals, Dr. Varaprasad Sir, Cardiac Anesthesiologist Care Hospital, and Dr. GKV Satyanarayana Sir, Associate Professor, GMC Vijayanagaram. Over to the moderators.
Hello all. So as a practicing anesthesiologist in day-to-day practice, we face a lot of emergencies perioperatively. Apart from airway emergencies, the cardiac emergencies, which include myocardial ischemia, cardiac arrest, severe hemodynamic instability, severe arrhythmias, or we can say pulmonary embolism, all these things we come across very often. These contribute a major part to the mortality and morbidity of the patient. So today we got Dr. Chandramouli, cardiac electrophysiologist. He will be using his expertise to bridge with our anesthesia practice in dealing with cardiac emergencies. He is a consultant cardiologist, electrophysiologist, device specialist at Yashodha Hospitals, and previously worked in Fortis Hospital and Trust Hospital, Kakinada also. He was awarded Executive Diploma on Artificial Intelligence and Machine Learning. He was awarded Heart Failure Certification by European Society of Cardiology. Awarded European Certificate as Device Specialist. Presented 4 presentations in international conference at Taiwan and multiple publications in national and international journals. Now I present you Dr. Chandramouli. Sir, over to you.
Thank you, sir. Sir, can I switch on my video? I'm unable to switch on my video. Hello?
Yeah, we are
Hello?
trying. Hello.
That's okay, sir. I don't know whether I can share the screen without this video option or not. But anyway, thank you, sir. Thank you. And particularly, I thank Dr.
No,
Particularly, I thank Dr.
able to...
Yeah, now I think I can share. So, thank you, one and all. First of all, no, my sincere thanks to all the anesthesiologist colleagues here, because you make our jobs very easy, you make our lives very comfortable. So, basically, I am a cardiac electrophysiologist. My job is to implant devices or do some emergency and all. So, without anesthesia support, no, my job definitely will be messy. So, my sincere thanks to all of you. And particularly my sincere thanks to Dr. Praveen also, who is a classmate, who MBBS classmate, so for giving me this opportunity. And hello, hello.
You are audible,
You are
sir.
audible mode.
Yeah,
But video is not there.
yeah, video. I
We
think
we lost your video again.
now it's sir.
So,
Video not coming, audio is coming only.
Audio, video, నాకు వీడియో వస్తుంది. No.
లేదు.
ఒక్కసారి షేర్ చేస్తాను. Can you see the screen now?
no, sir.
Screen? Huh?
No, we are not able to see this.
ఓకే, ఒక్కసారి నేను డిస్కనెక్ట్ చేసి మళ్ళీ కనెక్ట్ అవుతాను.
ఓకే.
Can you see me now?
Yes,
Yes,
sir.
yes.
Yes.
Yeah. Sorry, sir. I think the connection
No,
is
sir.
weak here. I'll start sharing my screen. I think you can see my screen, no, sir?
Yes, sir. Yes, sir.
Yes, yes.
Yeah. Okay. So to start with, no, when Praveen has said about this topic, perioperative cardiac emergencies, I'm a bit confused. It's like no asking a senior obstetrician how to or teach her how to deliver a baby in a cardiac patient. To me, it's like that because no, see, you are a better judge and you are better persons to manage a perioperative cardiac emergencies. But then I thought, of course, we can have something to learn and also basically it's a learning session for me. So initially, these topics and all are just for an academic interest only. So we used to read these topics as an academic exercise, but when I started preparing for this topic, then I came that it's a life-saving imperative, you know. So that's how my experience with this topic. So to start with, I'll be dealing with some of the emergencies which we generally deal in the in the OT. And and I'll be dealing as a I'll be telling my cardiology perspective rather than a general approach. So in the next few slides, I'll be dealing with some the ways to recognize some cardiac emergencies in the OR and recovery, and apply some evidence-based risk stratifications, and how to manage patients presenting with an acute MIs or arrhythmias or a heart failure intraoperatively, and ACLS protocols and some modifications in the ACLS protocols, and some of the uncommon cardiac emergencies like anaphylaxis, pericardial tamponade, or pulmonary embolism, and hypertensive crisis. So this is how I'm going to deal. And the last but not the least is patients with an implantable cardiac device. So this is my area of specialization. So I'm particularly interested in it. But before that, I'll be touching about the rest of the things, and I'll come to that as a last slide. To start with, so it's the framework for this perioperative uh, uh, perioperative safety starts with the preoperative evaluation itself. So it's a systematic approach basically. So it starts in the preoperative evaluation of the patient. So in the preoperative, what we can know is from the history, we can know the status of the underlying cardiac conditions and all. So we can evaluate the patient and we can risk stratify the patient preoperatively. So it helps in having some of the idea or anticipating some of the complications which the patient might be having during the procedure. And the next step is early recognition of the early recognition of the complications that the patient might have had. And next comes the response to it. Early recognition and immediate response to that, followed by a post-operative care also. This is a classical systematic framework approach for a successful perioperative cardiac emergency approach. So coming to the first part, like the preoperative evaluation, it starts with the risk stratification of the patient. Like why we need to risk stratify is it's for basically to triage the patient. So if we by risk stratification, we tell ourselves that this patient, some of the patients will be at a lower risk of having some cardiac emergencies, or some patients will be at high risk of having, so that no, we will be well prepared during the procedure. And maybe you better know about this risk stratification scores and all. Coming to this revised cardiac risk index, so which includes multiple parameters. Like some parameters are based on the history itself, like the patient, if the patient has any past history of CAD, CKD, CEA, or comorbidities like diabetes, hypertension. So these are all the parameters that are included in the risk scores. And apart from that, the type of the surgery is also important in a proper risk stratification of the patient, because one size doesn't fit all. Like the patient with a low risk surgery, like a patient for a cataract with similar comorbidities and similar risk factors, will be at a lesser risk when compared to the patient undergoing a spinal surgery. So this is how we risk stratify the patient, and based on this risk stratification, we can as well triage the patient also. So this is the subjective evaluation of the patient. And coming to the objective evaluation of the patient. So if we know that the patient had an underlying CAD, if the patient had any history of coronary artery disease, underwent some CABG or some PTCA, so we know that the patient definitely has some amount of risk. So such type of patients, maybe not only the subjective evaluation, we can as well go for a objective evaluation of the patients. And how do we evaluate that such type of patients? We generally go objectively depending on the condition of the patient. Like if the patient is fit enough, if the surgery allows, pre-surgical condition of the patient allows for a stress test, then the patient is subjected to a stress test to know about the functional class of the patient. And these are some of the tests. And the other modality of the tests will be blood test, simple blood test, like doing a routine anti-proBNP or a tropi. So these are the things by which we can risk stratify the patient. So this is the same thing, just adding some numbers to the risk factors that I have mentioned. So these are some, maybe we can say it's an arbitrary number. Single number may not be having a much significance. Like no, if the patient has a proBNP of 300, it says that patient has an elevated risk. But for me, it's the trends that is more important. Like the patient with a troponin of around 1 preoperatively, if suddenly it jumps to 7, probably so that throws a more significance rather than an isolated value of a troponin. That's why I say at this I say that we need to follow the trends rather than a single value. But to tell about particular numbers of the patient, like if the patient is subjected to any stress test, and if the patient can achieve a METs of around 4, that means he has probably a favorable prognosis rather than a patient who has a MET meets that METs of less than 4. Likewise, the risk index also 0 points. The MACE risk is less than 1%. The more the points in the risk, the higher the chances of patient having a MACE. So, and the other things are some some American American societies have given many risk scores. We can follow whatever we want, and everything ultimately boils down to a single thing, that is the risk stratification and proper triage of the patient. So, with this brief introduction, I'll just go through some of the scenarios which we commonly encounter. So, I thought I'll present it in a case-based scenario. So, I'll be dealing with some of the scenarios and the approach to that. So I'll start with this slide. A 65-year female who undergoing a total hip replacement, hip arthroplasty under a spinal anesthesia. Suddenly she developed a hypotension with a BP of 70 over 30, followed by a pulseless electrical activity. And monitor showed a sinus bradycardia, followed by a flat line, followed by a pulseless electrical activity. So basically it's a multiple choice like question I prepared. So the recent 2025 guidelines prioritize which action? Just remember the choices. I'm not going to discuss about the answer right now. So I'll be discussing the answers at the end of this this thing. So the choices are like we give a routine epinephrine or immediately do a focused ultrasound to identify the lethal trial, administer some soda bicar, or termination of the resuscitation if no return of spontaneous circulation after 10 minutes. So the next scenario is in a perioperative cardiac arrest, what is the modification that is done in the operating room compared to the standard ACLS protocol? That maybe these are the choices that I have selected, like a defibrillation, epinephrine, turn off the anesthetic agent, amiodarone. And the other scenario we can see is the patient develops a cardiac arrest intraoperatively after a brachial plexus block with bupivacaine, and the specific antidote is. So these are some of these three scenarios generally address different scenarios. Like the one patient has received a local anesthetic and developed a cardiac arrest. One patient, this question is regarding the modification of ACLS protocol, and this question is what immediately what we do. So with this, I'll just proceed further. So in such type of scenarios like the perioperative cardiac arrest, so the first and foremost thing is do not panic. No, we need not panic because no, it's an advantageous condition. Like everything is monitored, everything is controlled, particularly in the OR. The patient is very well monitored. So the chances of survival to discharge is almost around 50%. When unlike the out of hospital cardiac arrest, which has a very low uh, success rate. The first thing we can do is turn off the anesthetic, switch to 100% oxygen. If the patient is in abnormal positions, turn back the patient to the normal position or in a favorable condition, and then start looking for the causes. So the next important thing is identifying the cause. What is the cause? Like so the first and foremost, the most common cause for a cardiac arrest in such scenarios maybe hypovolemia or hemorrhage. If that is the case, then we need to give transfusions, we need to pump blood, we need to give fluids and all. So identification of this particular subset is very important. So for this scenario, so for this reason, we need to have a focused ultrasound intraoperatively or in the operating room. Um, Maybe if we can have if we can have it in by hand, no, it becomes easy for us to identify the cause. So immediately, if the patient arrested, immediately we do an ultrasound. We find that the IVC is collapsed or the RV is collapsed. Then we know that the patient is underfilled. We can start filling the patient. So that is the advantage of having an ultrasound. So that is one cause. Maybe the other causes are like electrolyte dyselectrolytemias or air embolisms. So these are all things, maybe some of the causes we can identify by using an ultrasound. Like if it's any embolism, like take for example a pulmonary embolism or an air embolism. So if we do an ultrasound or a focused examination, we can see the dilatation of the RA RV in that on the OT table itself. Then we can know, at least we can formulate a DD saying that probably might be this patient might be having some pulmonary embolism, and then we can start addressing the patient accordingly. So this is how we approach, and these are the modifications. So coming to the questions, so the first questions, what does the guidance prioritize? So immediately, the first thing is, as I mentioned, immediately do a focused ultrasonic examination, at least to identify the lethal triad. That is like pulmonary embolism, cardiac tamponade. So the answer to the second thing is, what is the modification? So as we discussed, it's turn off the anesthetic agent, switch to the 100%, and consider open chest. But I don't think it's an option in this position. So maybe what we can say is, just if the patient is in abnormal position, switch back to the patient, switch the patient to back to the normal position where the resuscitation is more favorable. So the coming to the third scenario, maybe I am not well versed with that scenario particularly because I have never seen a patient with a toxicity to the local anesthetic agent like bupivacaine. So this is one new thing that I have learned recently. So if we are suspecting like no local anesthetics or toxicity, the rescue therapy will be 20% intralipid emulsion, and the dose is around 1.5 ml per kg bolus followed by a 0.25 ml per kg per minute infusion. So we need to avoid calcium channel blockers, propofol, and vasopressin. Rest of the things we need to follow the ACLS protocol. So to sum up all these things, so the common causes for this pericardiac cardiac arrest are either it can be a hemorrhage or it can be a hypoxia. If it's a hypoxia, we know you better know what to do. Like we need to do a suction, do 100% administer 100% FiO2, or maybe we need to go for a surgical airway. So other causes like tension pneumothorax, if we are suspecting a tension pneumothorax, we can we can decompress by putting a needle, or we can as well insert a chest tube also. So if it's a dyselectrolytemia, maybe probably we can correct the electrolyte disturbance also. Like if the patient has an hyperkalemia, we can follow some anti-hyperkalemic measures, membrane stabilizing drugs like calcium gluconate and sodium soda bicarb can be given, and the effects of the dyselectrolytemia can be mitigated. And if it's a massive pulmonary embolism, then the approach again differs. That I'll be dealing in the later stage. And if you are suspecting an air embolism, So maybe we need to change the position of the patient, left lateral head down position. So that is how we approach this. And what does the guideline says? So never pump an empty heart. So aggressively volume resisted, and particularly if the ultrasound shows a collapsing RV. And the dose of epinephrine is definitely modified. It's not the routine 1 mg what we give. The dose is little bit small compared to the routine ACLS. And right now, the recent guidelines say that if at all if we have a TT, transthoracic echo or a transesophageal echo, it is generally recommended as a class 1 recommendations if we have that option of having those bedside. So this is one scenario. This is the way we approach if the patient arrested on the table. So this is how we approach. Coming to the next scenarios. These are the next scenarios are particularly cardiac scenarios, like patient intraoperatively patient having an MI, intraoperatively the patient having a heart failure, or intraoperatively the patient having some amount of some hypertensive emergencies. The next three scenarios I'll be dealing with these conditions. So to start with, this is a 68-year-old male undergoing emergency hip replacement who develops an ST elevation, particularly in lead 2, lead 3 AVF, and the blood pressure drops to 70/40. So what is the most appropriate immediate action? So basically the options are like administer IV amiodarone, IV esmolol, or stabilize hemodynamics and plan emergency PCI, or continue surgery and check troponin post-operatively. So these are the options. Coming to the other scenario, like this patient, definitely there is some ST elevation. So intraoperatively, we have noticed some ST elevation, particularly in L2, L3 AVF. So we could even localize the ST elevations to inferior wall. So probably the patient might have had an intra-op MI, inferior wall intra-op MI. So this is an ST elevation MI. This is one scenario. Maybe the next scenario is a 72-year male with multiple comorbidities undergoes an urgent laparotomy. The patient feels fine, minimal surgical pain on the post-operative day 1. After that, the patient had some amount of sinus tachycardia with borderline hemodynamics and but good saturations. Routine lab evaluations like a troponin shows elevation from 12 to 85. So this is what I am mentioning. So if we look at the trends, not a single value, because by definition, so if the patient has at least 5 to 7 times elevation of the baseline troponin, then we can consider that the patient had an acute ongoing MI. So this is one such scenario. Here, the difference between the previous one, this one is here there are no ECG changes. The patient is hemodynamically stable, and the patient has only minimal symptoms with only minor signs. So, and how do we approach this? What is the next best in such particular type of patient? The choices are like immediate heparin bolus and cardiology consult for urgent PCI, rule out non-cardiac causes, and optimize physiology. Check troponin again in 12 hours. If stable, no further action. Start aspirin and clopidogrel immediately. These are some of the options. The answers I will be discussing later. So coming to the perioperative MIs, so we can classify them into two types, like type 1 and type 2. Type 1 is basically the classical MI, what we see. It's because of the plaque rupture, plaque erosion and all. So there will be an immediate atherothrombotic plaque rupture followed by a blood clot, 100% occlusion of the coronary artery with an extensive infarction, which we can identify in the ECG by ST elevations. So this is one such type of scenario. Particularly intraoperative period are very stressful conditions. So because of that stress, there can be some amount of inflammation and there can be some amount of hypercoagulability state also, which may lead to this type of scenarios. Particularly if the patient had any history of previous CAD or if the patient is a heavy smoker, such type of histories and such type of patients can have this type of MI intraoperatively. The second type of MI the patient can have is type 2, what we call MI, myocardial injury, rather than it's it's not an infarction, maybe we can consider it as a myocardial injury in a non-cardiac surgery patient. Basically, it's a supply-demand mismatch. Because of the stress conditions, stressful environment during the intraoperative period, associated with that, the patient might be having some tachycardia, hypotension, anemia, hypoxia. So such scenarios are generally responsible for this type of myocardial injuries. And mostly these scenarios are clinically silent. Only routine examinations, routine blood tests, maybe trends will are helpful in identifying such type of MS. And so how to approach? So the approach to these two scenarios completely differ. Like the patient with the type 1 MI who is hemodynamically unstable has to be addressed immediately. So immediately the procedure has to be stopped. He needs to be stabilized hemodynamically, and if possible, if the patient can be shifted to cath lab for emergency revascularization and percutaneous intervention. When it comes to type 2 MI, the thing is, the first and foremost thing is to identify the correct stressors and correct the stressors. Like if the patient is anemic or if the patient is tachycardic, so if we correct those things, probably that itself can take care of this type of myocardial injury. So until unless the patient becomes hemodynamically unstable, uh, uh, there is no 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 need to shift the patient to the cath lab. So patient can be stabilized in the immediate post-operative period itself, and then once the patient is stabilized and out of that period, then he can be evaluated, and then he maybe we can treat him for his ACS at a later stage. So what do the guidelines say? So the 2024 class 2A mandate says all the patients who has a risk score index of greater than 1 with an age greater than or equal to 65 and a known CVD. So these patients should be screened for any cardiac abnormalities preoperatively. And the protocol is like we need to have a baseline troponin, baseline NT-proBNP. And postoperatively, we can have serial troponin values. And how to manage, particularly, we can start. Identification is the primary thing. Once we identify, start the drugs early. We can have an early initiation of the statins, and we can have an early initiation of the antiplatelets also. So probably with this, maybe the effect of that myocardial injury will decrease. And apart from that, other supportive medications like the favorable medications like beta blockers, particularly helpful if the patient had severe tachycardia. So beta blockers need to be initiated. They decrease the heart rate and thus decrease the myocardial oxygen demand. And the supply demand mismatch can be mitigated to some extent. Apart from that, the other drugs that have shown a benefit are like AC inhibitors and recently SGLT2 inhibitors. So these are the drugs that can be started in the immediate post-operative period. So this is the thing, same thing what I have mentioned. And coming to the antiplatelets, first thing is, so acute MI, first thing is stabilize the patient. Second thing is start the antiplatelets as early as possible. See, if the patient has a very high bleeding risk, at least start single antiplatelet, maybe an aspirin. We can give a stat dose followed by a maintenance dose of aspirin. And once that the bleeding risk is eliminated, maybe we can switch to dual antiplatelet therapy. And when it is mandatory, when it is compulsory to give a dual antiplatelets, maybe the choice will be clopidogrel rather than prasugrel or a ticagrelor, because those two drugs have high bleeding risks. So such maybe ecosprin and clopidogrel is a better option in these scenarios. And coming to the anticoagulation, we can think, but that too depending on the bleeding risk of the patient. So we can give some anticoagulation. And if it's an MI, ST elevation MI, immediately the patient has to be shifted to the cath lab and the PCA has to be done. And when the patient has a shock, in addition to that MI, if the patient goes into a cardiogenic shock, and that has to be addressed with any mechanical circulatory support, with some vasopressors or anything. These are all things I think maybe you can better manage. So the answer to the first question is stabilize the patient and plan an emergency PCA. So the same patient with a similar history, with a history of CAD, who underwent a CABG, now he is for a Whipple's procedure and he is undergoing a Whipple's procedure. And immediately post extubation, the patient becomes unstable with a drop in saturation. So a drop in saturation to 70%, tachypneic, and becomes restless. So how to address this type of patient? Probably this scenario fits into acute decompensated heart failure. Immediate post-operative period, the patients with an underlying CAD or with underlying multiple risk factors can have such type of scenarios. Like patient can have a immediate acute decompensated heart failure. So how to address this particular scenario is recognition is the first thing. And what are the triggers, sir? Maybe because the fluid balance is altered during the intraoperative period. That is one trigger. And sometimes the extubation, maybe during the extubation, there can be some amount of increased venous return. So these are all the factors that can precipitate a heart failure, decompensated heart failure, particularly during the immediate postoperative period. So how to identify it is by raising peak airway pressures, or if the patient has a pink frothy sputum, or if we are lucky enough to have an ultrasound, we can see the Kerley B lines, which suggests of some pulmonary edema. So that the approach to this is, first of all, the idea is to decongest the patient. So for that we can give IV diuretics, like whatever drug that is available. Like there is no difference between a furosemide or a diet or whatever. If whatever drug that is available in your OT, you can give. So, but it should be in an IV form. And come after the diuretics, what are the other things we can do is we can give is like vasodilators. We can give like nitroglycerin or sodium nitroprusside. All these things we can give if the patient is having an adequate BP. If the patient is hypotensive, anyhow we can't give all these things. Maybe at that scenario we need to reintubate the patient and maintain a positive airway pressure. But if the patient has an adequate BP, along with the diuretics, we can as well give vasodilator therapy also. The other drugs we can consider is giving dobutamine or milrinone, particularly in patients with a cardiogenic shock or very unstable patients. Maybe we can try with the milrinone. So these are the common drugs we particularly use in a patient with an acute decompensated heart failure, particularly in a post-operative period. The other thing I would like to mention is immediately post-op, like one patient by this is my personal patient. So for whom I have done a CRT, it's a cardiac resynchronization therapy. So we, because the patient has a severe LV dysfunction, we intubated the patient electively prior to the procedure, and the procedure went on well. During the procedure, his hemodynamics maintained everything. So immediately he was shifted. Following the procedure, maybe within half an hour, the patient was extubated. But next 5 to 10 minutes, the patient collapsed. The patient had a cardiac arrest. Probably, so in that immediately the anesthetist was quick enough to identify that and reintubated the patient. Probably what we thought it is inadequate reversal of the drug that was given. So his respiratory efforts were not optimized, and so he had some negative pressure pulmonary edema, following which hemodynamically he decompensated. So, but immediately after post, we intubated him. So maybe after another 3 to 4 hours, he settled. We could extubate him in the next day, and he was stable. Later, he was discharged also. So that is another scenario we need to think of. So the other scenario is maybe in this same spectrum, if the patient doesn't have, doesn't have an ADHF scenarios, the other scenario that the patient might have is a hypertensive emergency. probably intraoperatively or immediate post-operatively, the patient can have a very high BPs like 230 or 200, 230 by 130 or anything. These are the hypertensive emergencies which we generally see. And the main worrying thing for this is intracerebral bleed or an aortic dissection. So how to address these scenarios is my drug of choice, particularly, of course, textbooks will mention many drugs, but particularly my drug of choice is esmolol because it is easily available and it's rapid action and a short action. So, and the dose can be easily titrated. So my drug of choice will be an esmolol. So what are the other drugs that we can use? Labetalol or nicardipine. These things can be used. NTG is the last option we can consider. So this is one scenario, and the main aim to treat a hypertensive emergency is to avoid complications like intracerebral bleed or an aortic dissection. And particularly if it is an aortic dissection, so our target. So when we are addressing such hypertensive crisis, it's not necessary that we need to bring the blood pressure immediately. So we need to get it down by at least 30 to 40% in the next few hours. And then we can address, so we can gradually follow up the patient. But if we are suspecting any aortic dissection, then it becomes necessary to get down the BP immediately. And the targets are like systolic BP less than 120 with a heart rate of less than 60 as rapidly as possible. So we need to achieve this goal, particularly when we are suspecting a aortic dissection. Otherwise, maybe we gradually, maybe first few hours, maybe if you can decrease the BP by 30 to 40%, that's okay. Then we can address the rest of the BP further in the next following days. So these are some of the coronary cardiac emergencies which deal with the coronary artery disease. So, coming to the next topic, like perioperative arrhythmias. So, this is my topic. Basically, these are the common scenarios. No, mostly any cardiac surgery, any patient. Most of the calls for me is like any cardiac surgery or a patient undergoing a non-cardiac surgery. Most calls will be for arrhythmia rather than an MI. So these are common scenarios. So what are the common arrhythmias we can anticipate or we see in the intraoperative or immediate post-operative period is atrial fibrillations, VT, RVF, and some amount of sinus tachycardia. Other arrhythmias are also quite common, like ectopics, multiple atrial ectopics. These are also quite common, but the common scenario is like a atrial fibrillation. So next few slides, I'll be dealing with the ways to approach such scenarios. Like to start with, a 68-year female with a history of hypertension and obesity, 48 hours before the patient underwent an elective total knee replacement, arthroplasty. Then the patient suddenly reported palpitations, mild shortness of breath while resting in bed. She denies any chest pain or lightheadedness. On examination, her heart rate is 135, which is irregular. BP is quite stable with at least 100 by 70. Saturations are good. Temperature is quite normal. But when on examination, heart sounds are irregular with no murmurs, no S3, S4. That means there are no signs of heart failure also. And coming to the respiratory examination, chest is quite clear bilaterally. Other examinations, surgical site appears to be very clean, dry, intact, and there are no signs of DVT in both the lower extremities. And this is the ECG of the patient. So this is one common scenario. So what is the most appropriate next step in the management of this patient? So the choices are like immediate synchronized cardioversion or administered normal saline bolus, rate control with IV beta blockers or calcium channel blockers, or immediate initiation of therapeutic anticoagulation with heparin. So I'll be discussing each and every one. So such type of scenarios, what is most important is to identify whether the patient is hemodynamically stable or not. The second thing is the duration of the arrhythmia, whether it is a recent onset or if the patient even has a history of atrial fibrillation even pre-op also. These are the two things that we need to check immediately. If the patient is hemodynamically stable, that means we have enough time. We can examine the patient. We can address it in a leisure way. But if the patient is hemodynamically unstable, we need to shock the patient immediately. But at that time, we need to be careful that it is recent onset. If it is within 24 to 48 hours, immediately we can cardiovert the patient. Cardiovert the patient. Maybe at that time we can consider giving anticoagulations also. So coming to the patients with the hemodynamic stability, how to go about? So the thing is, in such type of scenarios, like the patient has immediate post-op, patient developed some arrhythmia with very minimal symptoms, mild chest, mild SOB, some chest discomfort. So all these are the minor things the patient has. So such type of rate. So the AF, two things we need to mention. Them identified as atrial fibrillation. Primary goal is rate control in the immediate period. So what are the drugs that are available? Maybe we can give IV beta blockers or IV calcium channel blockers. These are the two drugs that we can use for a rate control strategy. With this, the symptoms will definitely subside and the patient feels better. Maybe then we can address the rhythm at a later stage. The next thing is, once the rate is stabilized, the next thing is identify the triggers. What might have triggered? So in a cardiac surgery, definitely it is expected. So there will be a lot of manipulation during a cardiac surgery. So it is expected that the patient might have some arrhythmias, particularly atrial fibrillation. But in a non-cardiac surgery, it's not that quite common to have an atrial fibrillation. So we need to identify the trigger for this arrhythmia. And coming to the anticoagulation part, so in the immediate early postoperative period, the risk of bleeding has to be evaluated. And if it's a recent onset of AF, then so there is no urgency in starting the anticoagulation immediately. We need to risk stratify we can risk stratify the patient, like we have some CHATS-VAS score. Recently the TWAS sex has been taken off. It's a CHATS-VAS score now as per the 2025. So we can use that score. We can then stratify the patient, and based on that stratification, we can start anticoagulation. Because no single episode of AF, like the patient has a paroxysmal AF, that means the chances of that patient having further AF episodes is quite relatively high. So even if it's a paroxysmal AF, so it's better to do a CHATS-VAS and then start anticoagulation as per the score. So this is, I think this I have covered. So that is one scenario, like the patient has an AF. It's a relatively a benign arrhythmia, but the malignant arrhythmia, coming to the malignant arrhythmia, that is VT or VF. So when the patient has a VT, how to address the patient who has a VT or VF, either intraoperatively or immediate postoperative periods. So if it's the the approach is the same. So if the patient is hemodynamically stable, do a CPR, follow the ACLS protocol immediately. So if the patient is hemodynamically unstable, then we can evaluate the patient. Like we can know, we need to see what might have caused this arrhythmia. If the patient had a VT, which is hemodynamically stable, then we can start looking at the ECG. So like we can identify whether it is a monomorphic VT or a polymorphic, pleomorphic VT or a polymorphic VT. So if it's a monomorphic VT, maybe whatever, the drugs, if we want to treat by drugs, maybe the drugs that are available is imidrone. The other drugs that are available as lignocaine. Procainamide, of course, is not available in India. So the two drugs that are commonly available in India are imidrone and lignocaine. So particularly any type of arrhythmia, we generally use imidrone. But the problem with imidrone is it is highly toxic. It has multiple side effects, and so in such, but uh, we don't have any other option. Like no, we have another option like adrenaline, but that is not useful in patients who have a severe LV dysfunction. We need to be careful in such type of patients. So the other drugs that are available are lignocaine. That are available is a IV lignocaine. So particularly patients who has a dyselectrolytemia and a prolonged QT, such patients will be having pleomorphic rather than a monomorphic. Patient will be having a pleomorphic or a polymorphic VT. So such patients, we need to check the electrolytes and we need to correct
Dyselectrolytemia.
the electrolyte. Maybe because of the dyselectrolyte, patient might be having some QT patient. So because it itself can give drugs, maybe even if it's a hemodynamically stable condition also, we can as well shock the patient. And then once the rhythm is corrected, arrhythmia is corrected, we can take a cardiology consultation to look for the reason for this arrhythmia. It is regarding the VT. BF, there is no question, immediately start CPR and shock the patient or administer the drugs that are as per the ACLS protocol. So these are the two common arrhythmic scenarios we encounter perioperatively. So coming to the next scenarios, like the patient already had an ICD, patient with a severe LV dysfunction who had a ischemic heart disease. He received an ICD therapy. ICD is implantable cardioverter defibrillator. So right now he is scheduled for a laparoscopic cholecystectomy. So how to address such type of patients? Like which perioperative CIED management step is essential? The choices are like remove the ICD generator, suspend tachycardia therapy, apply external defibrillator pads, no precautions needed, or switch to MRI conditional mode. So coming to each and every choice, coming to the last choice, switch to MRI conditional mode is not mandatory. Particularly when we are planning for an MRI procedure only, switching on the MRI mode is useful because in an MRI, when we switch on the MRI mode, what happens is the device goes into asynchronous mode, like it goes to a DVOO or a VVO mode. That is the MRI mode. So till the time the patient is in high magnetic field, the patient will be in that MRI mode. And once he is out of that, we can as well reprogram it, or automatically after 24 hours, the mode will be reverted back to the non-MRI mode. And during a laparoscopic surgery, no precautions needed. This option I don't consider because it's an ICD, because the primary function of ICD is giving a shock. And when will the device gives a shock? When it identifies the patient has a VT or VF. And when we use a cautery, there are high chances that the device can misjudge it. Like no, it can misdiagnose the underlying noise as a VT and can unnecessarily deliver the shock. So that's why it's always important to switch off the therapies. At least switch off the therapies prior to the procedure and then take the patient for the surgery. So that is what is in the option B. We suspend the tachycardia therapies, and but if the patient has a high risk of having a VT, so it's always better to apply an external pads. But the only thing is that pad should be away from the device. It should not be on the device. At least 6 centimeters away from the device, the pads can be applied. So that is how we approach it. And particularly this is regarding ICDs. If the patient had a pacemaker, instead of an ICD, if the patient has a pacemaker, and if the patient is very dependent on the pacemaker, then maybe we can switch to asynchronous mode like VOO or a DOO mode before taking the patient for the surgery. So that is one change we can make preoperatively, and immediately post-op again we can change the mode to DDD or DDD, whatever mode. So this is regarding the patient with the implantable devices. Coming to the other things, like the cardiac tamponade, massive pulmonary embolism, the only thing that is important is identification. Early recognition is very important. So particularly in a cardiac tamponade, we need to have clear-cut suspicion. So we don't wait for the signs to appear. Like generally, our classical teaching is cardiac tamponade, look for the Bextroid. But in a intra-op scenario, it occurs in very less number of patients. So don't wait for the triad to develop. So have a high index of suspicion. So if the patient definitely has a hemodynamic instability, particularly a cardiac surgery, so think about a cardiac tamponade, do a focused examination if you can see pericardial effusion, or at least with a with a diastolic RV collapse. That is more specific. So if a collapse of the RA and RV, particularly RV with a diastolic collapse, which has a more specificity, that means the patient has definitely cardiac tamponade. In a cardiac tamponade, the first and foremost thing to do is pericardiocentesis. We need to tap it, immediately drain it. And the what are contraindicated in cardiac tamponade? Diuretics are particularly contraindicated because the patient will be having, so if patient will be having a high JVP because the neck veins will be enlarged, we think the patient is having high venous pressures. There is a tendency to give diuretics in such scenarios, but generally it is contraindicated because no RV is already underfilled because of the tamponade. So if we diurese such type of patients, there will be further collapse of the RV, which will be very detrimental. So that is one thing we need to avoid. And the other thing is avoid positive pressure ventilation. Whenever we are suspecting a cardiac tamponade, avoid keeping high PEEPs. So that is how we approach a cardiac tamponade. The other important thing is pulmonary embolism. Again, the way to identify is having a high index of suspicion, particularly if the patient intraoperatively or immediate post-op, the patient, so I'll tell you one of the scenarios. The patient had some pacemaker, the patient has a CH presented to our department with a CHP. So immediately TPA was done. Maybe 2 days after, because he has some cellulitis, so we kept him on antibiotics for the 2 days. And following the 2 days, once his cellulitis, the signs of cellulitis has come down, we have implanted a permanent pacemaker. So till that time, he is on a temporary pacemaker through femoral. So he was immobile all through this 48 hours. So following permanent pacemaker implantation, TPA was removed. The next day, the patient was mobilized. Maybe, but the patient is very obese, like he is 120 kgs. He has multiple risk factors like diabetes, CKD. So the third day after implantation, we thought of discharging the patient, and the patient is made to sit in chair. Then he suddenly collapsed. So at first it was a confusion, like because we didn't have this idea of pulmonary embolism at that time. So the first and foremost thing is we need to have that in mind that this patient might be having a pulmonary embolism. He is definitely at risk of having a pulmonary embolism that we need to keep in mind and suspect. Always suspect pulmonary embolism in patients who had a sudden collapse. Previously well resuscitated patient or a patient who is very stable, sudden collapse, the pulmonary embolism is one possibility. Then what we did is we immediately did an echo. We could see a huge dilatation of RA-RV. Maybe if we are lucky enough, maybe we can as well see the thrombus in the main pulmonary trunks also. But for us, it was difficult actually because of the obesity of the patient. We could only see hugely dilated RA-RV. There are some other signs like McCollon's sign or anything, but most probably we may not be able to see all the cells. The primary indicator in an echo to look for is dilatation of the RA-RV and a severe TR. With that suspicion, maybe we have sent the patient for a cardiac CTPA, which showed a bilateral thrombus in both the pulmonary trunks. So immediately we thrombolized the patient. So post thrombolysis, within 2 hours, the patient's saturation improved, heart rate came down, and patient hemodynamics stabilized. Unfortunately, later few other things happened. So there was some lead dislodgements. We need to open the patient. We need to open it again, re-implant the device again. So these are other things. But at that scenario, we could save the patient because we identified it as a pulmonary embolism. So I just want to mention only one thing, that perioperative pulmonary embolism is not uncommon. The only thing is we need to have good suspicion of it. We need to have that in mind, and then we can identify. Apart from that, if we have an ultrasound, develop the habit of doing an echo in all the patients, and so that we can identify these emergencies like a cardiac tamponade or pulmonary embolism. First, on the table itself, we can identify and we can treat accordingly. So this is, I think, anaphylaxis with a cardiovascular collapse. Probably, I have never seen this. First thing, for a completion sake, I have added this. Probably you people know about this, how to deal with the patient with the anaphylaxis with the cardiovascular. So the key takeaways are risk stratify preoperatively, and so myocardial injury in a non-cardiac surgery is a common and lethal condition. Troponin surveillance saves life. Epinephrine is the cornerstone of anaphylaxis management. The important thing I just want to touch in is all these points is ultrasound. Having a bedside ultrasound will make your life easy. So it helps us to identify the conditions of the scenarios immediately so that we can approach the patient accordingly. So that is one thing I just want to stress. Thank you.
Thank you, Dr. Mouli, for excellent presentation. I updated all the protocols, I think, for recent updates regarding all cardiac emergencies. This session is open for discussion. Anybody?
Molly, we have one question in the chat box.
Okay.
One member was asking, can we start noradrenaline instead of dobutamine first in acute heart failure?
That depends. Yeah, you can start. There is no contraindication for norepinephrine. We can start. We generally start dobutamine because it's an inotropic drug, no? So that's why we prefer dobutamine in a cardiogenic shock condition. But there is no contraindication for norepinephrine. We can as well start that. But the scenario, maybe the downside for both norepinephrine and dobutamine is if the patient is having high heart rates, if the patient is tachycardic, we can't even start both. Like dobutamine, still we can't because the risk of having AFib or VT is very high with dobutamine. But even the risk of tachycardia remains even with norepinephrine. Compared to in comparison, norepinephrine has less effects, less tachycardic effects than dobutamine. So these are the things we consider, we see before starting.
After starting, the dobutamine patient develops hypotension. And what is the drug? Is it a drug? What is the drug of choice? Is it noradrenaline or something else? Sir? We can stop the.
Yeah.
We can
So
stop the patient. Most of the time, we'll see most of the patients in heart failure. When you start a dobutamine, the patient develops hypotension.
Yes, sir.
Then
so that is one common scenario we expect with the dobutamine. So in such scenarios, the thing is to stop dobutamine, or otherwise, in addition to that, we can as well start other vasopressors like norepinephrine or vasopressor.
Yeah, volunteer dopamine, but they are now the recent all the guidelines says norepinephrine. All
Norepinephrine, sir. Dopamine nowadays we are not using dopamine that frequently, sir. Even adrenaline also, for that matter, we generally don't use adrenaline.
Yeah.
So in the same way, dopamine also. Maybe now the drug of choice is norepinephrine.
Yeah. Now in all the shock, whether it is septic shock or cardiogenic shock, any shock,
Cardiogenic shock.
now the only previously we are used to use some dopamine or thing, dopamine
Yeah,
everything.
yes,
But now it is only drug of choice is noradrenaline. No
Noradrenaline.
any hypertension, you should give only noradrenaline. Okay, sir. Thank you. Thank you very much for a wonderful presentation and enlightening us.
Sir,
Thank
you, sir, for excellent lecture. I'm Dr. Anuradha. So,
Thank you.
Care Hospital. I think, do you remember?
Yes, ma'am. Yeah. Ma'am.
Sorry, sir.
Right,
Sir, we are regularly seeing stress cardiomyopathy cases after a post-op or intra-op also. Suddenly patient have hypotension, tachycardia. So after that we diagnose stress cardiomyopathy. Accordingly, we are starting the inotropes and we are treating for 2-3 days. After that is stabilized, his recovery is okay. Next, second thing is MI. Introp MI, we are treating, we are immediately inform the cardiologist, and accordingly what they suggest, accordingly we are treating. That is the in MI also we are regularly seeing. But in pulmonary embolism, we are especially for ortho cases, we are giving the spinal. So introp is okay. So when patient shifted to OT to ICU, when shifting the patient, one patient have suddenly unconscious, hypotension and tachycardia like this. Immediately echo done, same pulmonary embolism, huge mass in RE and RV, and the septum deviated to LV side. But we tried, but immediately we informed the cardiologist. We started the drugs thrombolysis therapy, but cost wise also some patient family discussion, and they are poor sometimes. Yeah, they are a little bit tricky that time. So counseling also important, because when patient is going to the OT, patient is conscious, is talking, and after patient shifting the ICU, immediately unconscious, almost arrest CPR and like this one scenario. Second scenario, spinal given during the procedure, after 30 minutes patient suddenly gone to tachycardia, hypotension. So we abandoned the procedure and shifted to ICU, and same thrombosis there, pulmonary. So these are the situations occasionally we are seeing. So but we are losing the patients. So how to treat, sir, that time?
Ma'am, see, as far as I understood, what you are dealing with is a massive pulmonary embolism. Whatever we do, maybe 50% mortality might be there. But such scenarios, the first and foremost thing is thrombolyze the patient immediately. Thrombolyze it immediately, ma'am. If of course, if there are any contraindications, then we need to weigh the risk between the benefit and risk. But massive pulmonary embolism, thrombolyze the patient. Don't wait for the mechanical thrombectomy. Right now we have many mechanical thrombectomy devices, but that would be a time waste. So first of all, thrombolyze the patient. If the patient is not stabilized, shift to the cath lab. Then we can do a mechanical thrombectomy. We can as well do an aspiration of the thrombus also. This is how we can approach. And apart from that, what other things we can go is we can as well put a mechanical circulatory support. So some mechanical circulatory support systems we can put. We can as well intubate the patient back, and some circulatory support systems we can put, and then other subsequent therapies.
So mechanical support means that also very cost effective. I mean, practical wise means it very difficult to tackle that time.
Yes.
But guidelines, according to guidelines, we have to go one by one. That is easy. Suppose in thrombolysis therapy, altiplase is taking some next. Other than any drugs are there, only altiplase.
Altiplase, tenecteplase also can be given, ma'am.
Altiplase and tenecteplase.
And tenecteplase can be given.
Okay, sir.
Streptokinase, I think it's out of favor. Maybe,
Yes, sir. Yes, sir.
tenecteplase, definitely, ma'am. I have seen much very good benefit with both alteplase and tenecteplase.
That
Within half an
immediately
hour,
we can see the thing.
yeah, we
So,
can notice the change.
yes, sir. Next, one more thing, when patients we are taking, ejection fraction 20%, 25%. So hemodynamically stable also when you are keeping in the OT and some that time if heart rate is okay, so we can start dobutamine, but 2 ml or 3 ml, 5 mics, 2.5 mics like this.
Yes.
After the procedure, we can shift and slowly wean up the things. And
Yeah.
sometimes very high risk, we can't give the fluids. With inotrope only, we are managing some cases.
Yes, ma'am. And moreover, the problem with dobutamine, it has tachyphylaxis. Maybe if you give for a prolonged period, no, it also doesn't have that much effect. So only for a brief period we can give dobutamine, provided the heart rate is not too high.
Yes, sir. Yes, sir. Thank you, sir. Thank you so much.
Thank you.
Dr. Varaprasad sir, Vijayakant sir, Satyanam sir, any more questions?
It's been a very good presentation. Thank you very much, sir.
Thank you, sir. So somebody has asked last why vasopressin is avoided in last. So that's in the chat box. I could see that because vasopressin itself is a vasoconstrictor. It further reduces the cardiac output. So that is generally avoided. That is the reason why we avoid vasopressin.
So any more questions? Thank you, Molly, for a wonderful presentation.
Thank you. Thank you, Praveen.
Anything more you want to add?
No,
Actually,
nothing.
we used to talk about Molly as once the world starts sleeping, he starts reading. We always thought that he will be settling as a cardiologist, and so he is. Thank you, Molly, for accepting the invitation to give a talk to ISA Visakhapatnam City Branch. On behalf of ISA Visakhapatnam.
Very nice initiative from that from ISA Visakhapatnam. Very nice initiative. Particularly, I would appreciate Dr. Praveen for it, and I particularly thank you also for giving me this opportunity. At least I had that opportunity of meeting my old colleagues. I could see the contents. No, some Anuradha madam, I know you. I think Vinila also joined. So 4 or 5 names whom I know at least are there in the group. So very happy to see them all.
Thank you so much. Sir, if there are no more questions, shall we call it a day? Vijayakant, sir?
Yes, sir. Yes, sir. I think there are no more questions. Anybody?
Thank you.
Role of
Any more
Mirno
questions?
on RV dysfunction.
Sir.
Role of Mirno on RV dysfunction. I'm asking.
Sir, Milrinone RV dysfunction. Maybe as a tide over drug, we can use it, sir.
Okay, sir.
Yeah. RV dysfunction, right now, no drug has proven much benefit. Maybe so the only right now, what we are using is as an OP patient, we are giving Versicuat, all these drugs. But on an acute condition, maybe as an offline drug only we use.
Okay, sir. Thank you.
Thank you, Molly, for the wonderful presentation. Thank you, Vijayakant sir, Varaprasad sir, and GKB Satyanarayan sir for anchoring the session. We'll be meeting in our next pod session scheduled on April 29th. Thank you, one and all. Good night.
Thank you. Good night. Good night.
Thank you, sir. Thank you all.
Thank you, sir. Thank you.
Thank you, sir. Thank you to all.